Hello, everybody. My name is Andrew Cairns. I'm a consultant perinatal psychiatrist, but I'm also the lead psychiatric reviewer for MBRRACE. You're probably aware that we last reported on mental health deaths in the 2021 report. But looking at the data coming through from the deaths in 2020, we had a number of concerns and wanted to make you aware of these. And so I've written a chapter for this current report. You may remember that in the 2021 report, we mentioned some potential concerns about an increased rate of teenage maternal suicides, and also concern around the capacity of specialist perinatal mental health teams to see all women who needed secondary care mental health support, and to not include women who might have diagnoses such as personality disorder. In terms of the substance misuse deaths, we had some concerns around a number of cases where women were either prescribed or taking illicit pregabalin or gabapentin. And overarching, the majority of the cases was a pattern of trauma and multiple adversity, which you'll be familiar with from the past couple of reports. Again, you'll be familiar that when we look at the women who've died between 6 weeks and 1 year postpartum, the late deaths, the leading cause for a number of years now has been mental health causes. Of concern is that this proportion does seem to be gradually increasing between each triennial period. So when we look back to the 2018 report, which looked at women who died between 2014 and 16, the total proportion of suicides and substance misuse related deaths was around 31%. This increased to 34% in the 21 report. And looking at those women who died during 2020 alone, that proportion is around 38%. The difference from last year's report being an increase in the proportion of substance misuse deaths. The key concerns we had looking at the 2020 data were a significant increase in the number of women dying during pregnancy and up to 6 weeks postpartum. From the years 2017 to 19, we had 10 women dying during that triennial period, but a further 10 women died through suicide during 2020 alone during this period. And that is a statistically significant increase, relative risk of around 3 times. We also saw a further continuation of the trend that we reported on in the 21 report in increasing teenage suicides, and I'll explain a bit more about that in a moment. Looking at all of the young mothers who died in their teenage years, they all had a very similar pattern of their children being taken into care, their own complex problems around mental health, substance misuse, and domestic abuse, fitting very much with that pattern of multiple adversity which has previously been described. When we look at associations with domestic violence, then there was roughly a doubling of domestic abuse rates, both in those women dying through suicide and through substance misuse, when compared to the previous 3 years of 2017 to 19. Just touching on the characteristics of the women who died, there were 28 women who died through suicide during 2020, and 27 who died through substance misuse related causes. And that compares to 62 and 58 deaths in the preceding 3 years. When we look at domestic abuse, the increase was from 18% of suicides to 32% of suicides in 2020, and from 31% to 70% of substance misuse related deaths during 2020. And elsewhere, there has been evidence published showing that there has been an increased rate of domestic violence and domestic abuse during the COVID pandemic. When we think about recommended levels of antenatal care, the rates were very similar in those women who died through suicide, but there was a large change in those women who died through substance misuse, where in the preceding 3 years, 26% of the women had accessed recommended antenatal care, but that was down to 12% during 2020. And one could hypothesize that that may be related to the changes in maternity services that occurred during the beginning of the pandemic. I mentioned at the start concern about an increasing trend around teenage suicides. Thankfully, the absolute numbers are relatively small, but we've seen a shift from the 2018 report and preceding reports where the level was relatively static. In the 2018 report, we found a rate of 2.5 per 100,000 maternities. In last year's report, we reported an increased rate of around 11 per 100,000 maternities, and that represented 7 teenage mums who died during that 3-year period. And during 2020 alone, there were a further 5 suicides, and that gives a rate of 27 per 100,000 maternities. And this is a statistically significant increase, so a relative risk compared to the 2014-16 data of about 11 times. When we think about the mode of death and mode of suicide, this has remained relatively static over many years now. Hanging remains the leading cause of maternal suicide at around half of the cases during 2020. In the last report, we'd seen deaths through overdose increasing in proportion, and that remains the case in 2020. So that was the second most common cause of maternal suicide, followed by other forms of violent death, jumping from heights, jumping in front of trains or into traffic, taking up the majority of the remaining deaths. In previous reports, when we've looked at the timing of maternal suicides, what we've typically seen is a much increased rate of deaths occurring in the postpartum year. In earlier reports, that tended to drop off towards the end of the first postpartum year. In more recent reports, and particularly in the 2021 report, we saw a very consistent level of suicide throughout the year, but lower levels during pregnancy. And as I mentioned at the start of this presentation, we saw an increased rate of suicides during pregnancy and up to 6 weeks postpartum. And so when we look at this graph of timing, we see now that shift, particularly with those early deaths becoming more common and a more of a spread throughout pregnancy and postpartum period. So if we move on just to briefly think about a couple of cases. Thinking about the teenage deaths, we had a case of a multiparous teenager who'd had a miscarriage shortly before her death. She herself had a history of child abuse and previous involvement with child and adolescent mental health services. She also had a history of substance misuse and domestic violence. A diagnosis of bipolar affective disorder had been raised, but our assessors considered that this was unlikely. She'd been referred to the perinatal mental health team, but they declined this prior to her death by suicide. And this case raises a couple of issues that I've already referred to. One is this pattern of multiple adversity, which is becoming an increasing feature of many of the women who are dying through suicide and substance misuse. And the second is the importance of specialist perinatal teams having the ability to become involved with all women who have complex mental health problems in the perinatal period. So in terms of recommendations, it's important that we recognise trauma history in our assessment of risk and involve specialist perinatal mental health teams where there's either a history of significant involvement with secondary mental health services, and that could include child and adolescent mental health services as well as adult services, or where there is significant risk, either past or current. And particularly where this is a first pregnancy and we do not have the benefit of prior pregnancies to help us understand how this woman will adjust in terms of her mental health to becoming a parent. We also recommend that access services such as psychiatric liaison teams, crisis teams, and street triage teams should alert the specialist perinatal mental health teams to any referrals of self-harm that they receive to allow the specialist teams to triage the cases for the need for ongoing follow-up. And finally, it's important that commissioning bodies should ensure that providers of specialist mental health teams have sufficient resource both to advise and, in those complex and high-risk cases, become directly involved, particularly in initial assessments when they occur in working hours. Just briefly thinking about a further case, we had a case of a non-English speaking woman who contacted her health visitor 3 months postpartum, concerned about her baby. She herself had not slept for over a week, and it was clear from the notes that this was quite a severe insomnia. She was directed to the emergency department, where a psychiatric liaison team were unable to identify any low mood using a telephone interpreter. She was not referred on to a specialist perinatal mental health team, but she was commenced on an antidepressant, although she did not continue it as she was breastfeeding. A week later, her health visitor did refer to the specialist perinatal mental health team. She was called by a member of that team within the week after referral, and they offered a talking therapy, which she declined. She was referred again to the specialist team, who suggested that she should attend the emergency department, but they themselves didn't attempt to coordinate any form of urgent assessment, and she died by jumping from a height 3 days later. And our concern in this case was particularly around the ability of teams to offer direct assessments, face-to-face assessments, particularly where multiple referrals were being made with concern about mental state. And also the very severe insomnia that this particular woman and other cases that we saw was suffering, that wasn't particularly responsive to treatments that were being offered, which did include sleeping medication. Our recommendations here were of the importance to assess directly women with persistent and severe insomnia, carefully looking for signs of underlying mental illness. The importance of being alert to factors such as cultural stigma, fear of child removal, which may influence the willingness of women or their families to disclose symptoms of mental illness, thoughts of self-harm, or substance misuse. And also, when we were looking at the records, clearly many teams now have moved over to electronic records systems. And we were concerned about the opportunity that professionals had to make written descriptions of the patients that they were seeing, as opposed to using tick box approaches. And so we made a recommendation that it's important that there is sufficient opportunity within electronic record systems for free text comments, rather than relying solely on tick boxes. And where a woman has a history of mental health difficulties, then we would expect all professionals to be able to make a brief comment on mental state, mental health, much as they would do for physical health. So this is not a recommendation, for example, that people should be doing an in-depth mental health assessment, but at least commenting on presentation and mood and that sort of thing. So finally, just touching on some of the findings and recommendations, you will have heard around the current report that we continue to see an increased rate of women who live in deprived areas who are dying. The majority of deaths obviously are occurring within the postpartum year. When we think about multiple adversity, we're now seeing 1 in 9 women who die who have severe and multiple disadvantage. And as I've mentioned in this talk, we've seen a significant increase during 2020 in those women dying during pregnancy and up to 6 weeks postpartum. Thank you.